And cardiologist. Here with me, there are three other distinguished cardiologists. Dr. Niyomali Amarasena from Sri Jayadunwar Hospital, Head of Cardiology Unit, and Dr. Roshan Paranaman, Consultant Cardiologist from National Hospital, Colombo, and Dr. Vasanthi Ratnayaka, Consultant Cardiologist from Kalutara. And today's very unfortunate incident, we have been informed by the guest speaker that he is unable to participate with us, but nevertheless we have a good case to discuss and we'll be in live. Yeah.
Thank you very much, sir. So, okay. Right. So we are going to discuss actually only one case for the interest of time. And Madam, would you like to give an introduction before we start the case? Madam, you can start from
You
here.
can start here. Yeah. Yeah.
Okay, good afternoon. Well, to just give a basic introduction to bifurcation lesion.
Can somebody please clear the slide?
There's some also the things coming. Right, okay. Yeah. Essentially, bifurcation lesions are 20% of all stenosis. It's also known that it's associated with a higher rate of restenosis and repeat revascularization following PCI. So provisional stenting still remains the mainstay of treatment, and this has been supported by multiple randomized trials. However, recent trial data has shown that in certain instances, DK crush may be superior to provisional stenting and QLOT. Next slide. Roshan, next one.
So not moving.
Not moving. Right, okay. So this is really what is called the definition criteria for complex bifurcation lesions, where you have major criteria and minor criteria. If you look at the major criteria, it's really all to do with the side branch lesion length, where it's the left main bifurcation with a side branch lesion length of more than 10 millimeters and a diameter stenosis of more than 70%. And it's a non-left main bifurcation. It will be with a side branch lesion length of more than 10 millimeters and a diameter stenosis of 90% or more. There are certain minor criteria, which is either greater than mild calcification, multiple lesions, bifurcation angle less than 45 degrees or more than 70 degrees, main vessel reference diameter of less than 2.5 millimeters, main vessel lesion length of more than 25 millimeters, and thrombus containing lesions. So these are really the complex bifurcation lesions, and these are the cases where you would consider using a DK crush technique. Yes, and I would like to hand this over to Dr. Stanley Amarasekara to take on the description of the different types of techniques we have for bifurcation stenting.
Yeah, actually, when you take, there are so many crushers, right? As we see in the real field, there are mini crushers and or nano crushers and classic crushers. That is where the crushing stent, the side branch stent is brought into the main vessel to touch the wall of the vessel. So that is a classic crush. The mini crush where you the nano crush, the crush comes, the stent is brought in not only to the bifurcation, about 1 millimeter or just at the level of the bifurcation. The fully crush, you get the 2 millimeters or little more than the carina level. So these are the three. But the difference is where you get the one kissing, that is you get the kissing with the side branch, one kissing or two kissing. That is how the DK crush comes in, where you do two kissings, and now the two kissings are accompanied by a proximal optimization with the pot technique. So this is how it's being described. But in QLOT, is another technique where you put the stent, branch vessel stent first and then the main vessel secondly, where you take the stent little away from the carina and you do the two kissings. And the difference between decay and culotte is where you see less number of struts coming into the main vessel in those two, but the kissing is going to be probably a single kissing in culotte. So that's the main difference. But I would like to ask Roshan and
yes, sir. Now
Vasanthi to comment on as to when you decide two upfront stenting, what are your comments, or when you decide main vessel stenting and a provisional stenting state.
So when we deciding to go for a main vessel stenting or going for a two-stent strategy, there are many criteria. Muller's criteria as well as the Finner's law we have to apply. And when you have a side branch where you have to preserve, even in acute primary PCI setting, sometimes you have to go for a two-stent strategy. Selection is, I think we all, as an interventional cardiologist, we follow the rules to protect the side branch. Comparing between DK crush and the culotte, I think DK crush we always keep the main vessel wire as it is. And the culotte we have always changing the two wires and two times crossing the side branch and the main branch. So DK crush is more, have a two-time kissing and the steps is little more, but it's more preserve the side branch and carrying an angle and the displacement of the plaque is less in DK crush. And the advantage is you can put in culotte, actually you do the only final kissing at final level. And that is the two different in culotte and DK crush. Both applying when there's an angle more than 70%. And if it is less than 70%, you can go for either different method. But DK crush and the culotte selection is similar angle, similar size of the main and the side branch. And the difference is DK crush, you always keep the main wire as it is.
Yeah, I think Vasanthi said everything. Now, I just want to ask her, now earlier days we were actually fond of this mini tap technique. Now we cross over to the DK crush. I think last year after the Europecia we all, I think, swap over to this DK crush. Do you feel any clinical significance?
Yeah, now Roshan, it's very important because the DK crushes, so far we have got DK crush 1, DK crush 2, DK crush 3 trials have come up, and these trials have shown there is a big benefit. And particularly, but these DK crushes, one has to remember that these operators are very experienced operators, so that operator feasibility, that their experience and their likeliness towards this technique is going to be very important. Now, if you're going to do first time DK crush, it's not going to be little easy. So if you are starting with this, probably you got to start with a colleague and then get experience and do it. I think what is important is for our colleagues to, whoever is more familiar with their technique, that they must use it. But in the literature, what they say is right now the studies have shown the DK crush is superior to other two techniques, depending on the long-term target vessel revascularization and also the thrombosis rate.
Yeah.
So the one more thing is that we must always remember, where you put more metal, you have more problems, more thrombosis. Where you put less metal into the heart, you have less problems, less thrombosis. So therefore you must finish with the least number of stents in these cases, particularly.
Yeah. So having actually talked about everything, I just want to discuss a case, as we had only short notice and we had to find a case. So I would like to hear from one of our fellows, the senior registrar, to describe this coronary anatomy. Would anybody like to
Can you all
describe?
see this picture? Are you, anybody volunteer to speak about this?
Yes, please.
This is a LAD and a diagonal in a epicranial view.
Yeah. Can you all appreciate there's a bifurcating vessel?
The diagonal
Yeah,
and
can one of you describe? Rasika, why don't you? Rasika? Yeah. Mike, please. Corner. We have limited views, I think, because this is a...
Yeah, we can see left main engage, there's a complex going downward. Then LED D1, there's an angle less than 70%, it diagonal 90% ostial lesion.
Yeah.
And almost
actually it's a 111 lesion involved in both main vessel and the side branch as well as the distal vessel. So it is a true bifurcating lesion. So having this thing, I would like to ask you, sir, what is your preferred choice of intervention for this kind of lesion?
Yeah, now the question is, now this diagonal, is it significant diagonal?
Yeah.
Looking at the guiding catheter, which is 6 French or
6 or 7
6 French.
7 French, I think, no?
Yeah, 7 French. If it is 7 French, it's 2.5, and the diagonal looks little, at least 2.25, and it's more than 6 centimeters, and the lesion in the diagonal is more than 10 millimeters. So therefore, I think the diagonal, one has to appreciate that the diagonal supplies a considerable area of myocardium, which is definitely more than 10% or 15%. And if you compromise this diagonal, the patient is going to infarct the diagonal area. So we need to preserve this diagonal. Number 2 is that LAD has got the bifurcation lesion. Everyone appreciates its proximal and also distal to the diagonal. Therefore, at the time of the stenting of the LAD, there is very likely that this diagonal is going to occlude. So I think we have 2 techniques. One is the main vessel stenting and a provisional diagonal stenting. The second method is to upfront 2-stent strategy. I would prefer to go ahead with a 2-stent strategy for this. But definitely you are at a decision to decide on whether you are going to have a provisional stenting.
Yeah.
Yes.
So when you see this site, you know that you have to have upfront 2-stent strategy. So if you put provisional stenting, then of course I think you can't do provisional, I suppose, because the lesion is more than 10 millimeters, more than 5 millimeters, and plus the lesion vessel is at least 2.5. So I think you have to decide the upfront 2-stent strategy. So as you say, it could be a culotte or a DK crash, yes.
Yes, I appreciate Vajra. I think we should go ahead with the culotte technique or a DK crash in this upfront.
Yeah. So, madam, would you like to add anything?
So decided to wire the 2 vessels.
Yeah. So actually, having decided to go ahead with DK crush, so then operator decided to wire both main vessel as well as the diagonal. Right. So can you describe those the step by step, sir? Then our listeners will be more familiar with this. Now,
you have the diagonal wire and the LAD wire. So what you are supposed to do is, now in a DK crush, you have to keep a balloon in the main vessel, and also to first you prepare the lesions. So you need to balloon both diagonal and the LAD. Then you keep the balloon in the main vessel and bring the stent, park the stent in the branch vessel, and keep a 2 millimeters from the carina. That's what's been shown in the diagram. Then you place your balloon across the stent, or the balloon is across the stent. Then you crush the stent. After that, you recross the diagonal. Once you recross the diagonal, you need to do a first kissing. So that is going to be very important, because the value of the DK crush is to keep the carina fully covered and and undistorted stent minimized.
Yeah, I think, sir, now, sorry to interrupt. I think the most important thing is this first step, because you have to make sure you are keeping the main vessel with the balloon ready, and then you have to deploy the side branch stenting. So if you do it without a balloon, then you are finished. Most of the time you won't be able to perform this DK crush. Then you have to shift over to the crush
This is a
technique.
very important trick. You must always keep the balloon in the main vessel. Don't postpone that. You may not be able to bring another balloon to this point. If you don't have a balloon, placement of the stent may be too much and you will be in trouble probably. Yeah.
And please make sure that you deploy the side branch stent and pull out both the balloon and the wire out before you do crush, otherwise you won't be able to.
Yeah, the next step, yes, as you said, sir. Now the next step, so then once you deploy the stent, you have to take it out, then with the balloon crush the side branch stent.
And when you cross, it's most important to make sure that you cross the proximal stent proximally rather than all the other techniques, culottes.
You have to cross the distal most.
But here on only occasion you cross
So
proximal.
this is
the most important,
very important step and a trick. That the stent gives you a proximal crossing and a distal crossing level. In the DK crush technique and in the tap technique, these two techniques you must cross in the proximal part of the stent. The other two techniques like culotte and fully crush techniques, classic crush technique, you must cross in the distal segment of the stent. So you have the carina, your crossing is proximal in a DK cross. But whereas in a culotte, it's a distal cross.
Does it make any difference? Because now you can say sometimes we won't be able to do it when we perform this. It is very difficult. We don't know whether it is going to the proximal start or the distal one. So is there any like how?
You must make sure that you cross the distal start. Otherwise, because I can't demonstrate because there are no pictures, I can't do drawings. But here, what happens here is when you deploy the second stent, it is crushed towards this side. If you go distal, there will be a huge bulk of stent on this side, carina. So if you go proximal, then you can open it down. Then the diagonal, the distal wall is covered. If you go distal, then
it will come to the proximal, yeah.
And that causes the abdominal carina. That causes restenosis.
Yeah, then your purpose also not achieved, so yeah.
Yes, otherwise when you have the fuller you always have to go distal.
Yes.
To make sure that otherwise the distal part, I can't show without diagram. It covers both sides of the side branch if you put it distal and bring that part of the strut towards the wall. So it covers the both sides. So it's a must.
Now I think you should do more and more cases. This is why the experience is going to make you more easier when you're trying to do bifurcation two-stand strategy.
So then after,
yes, then comes to the first kissing. Now this is going to be very important. Crush. First you crush the stent. Secondly you kiss the two stents. Kiss the one stent. But the main vessel will be having only the diameter size balloon, not a higher diameter balloon. So make sure that your stent will not dissect your vessel. Therefore your opening of the balloon is going to be equal to the size of the diameter of the vessel. And you do the first kissing.
Yeah. So this is after the first kissing, and now the main vessel is free. Then you can move the second main stent into the LAD. Right. So this after the first kissing again. Yeah. So place the LAD stent and take the wire back and deploy it.
Yeah, another important thing here is that when you are deploying the second stent, you are not keeping a wire across the branch, because you get the metal to metal, the wire can be broken or cut. So therefore you are not going to jail that wire at this point.
So that's why I always say on main wire we are not going to change in DK crash. We keep the wire, and after the second stent deployment,
Yeah.
Now you need to rewire the branch. Now in this case, as you see the previous slide, please get the previous slide.
Previous one. Please.
Previous one.
Yeah.
Okay, just hold on. Now you can see keep the slide as it is. Now you can see the side branch stent, proximal end and the distal end. Then wiring can be done proximally in this case because it's visible.
You can see it very nice here. So the previous
Distal,
stent and the new
distal.
stent, yes.
Distal side. Then costano distal. Right. Then we have recrossed and
Yeah, once you recross, then you balloon it, then you do the kissing.
Okay.
the final kissing.
Sorry.
sorry.
I think only a few
The last
slides
one.
because
Yes.
yeah. I think Madam is going to give you a demonstration on how to do
Get
it.
those first slides.
Yeah.
This lecture is supposed to do by the Hungarian lecture. Unfortunately, at last moment, just now only he conveys the message is not ready. So we all not well prepared.
So we had to get ready in
Yes.
record time.
Actually took trouble to do the arrangement.
Yeah. So the
Yes,
thing is, this is just the theory part. Now you can see these are the original classic crush, and you can see it's a very relatively short procedure where you remove the balloon once you deploy the side branch stent. You remove the balloon and the wire, and you crush it with the main branch stent. Then this is the mini crush technique. And here you can see that you have gone, depending on what kind of this guide catheter you use, because you can see that you have to use more steps if you are using a 6 French. So you are actually better off with a 7 French, because where you can straight away go with your main branch stent to go and crush it. Because in the 6 French procedure you have to go just one more step further. But you can also see that there is some potting also done. And this is the diagram of the DK crush. Now here, as you can see, you first do the side branch stent while keeping that main branch balloon, and then you having done the initial crushing with the single stent in place, then you go ahead and then finally deploy the main branch stent, and then you go in and pot proximally, so that this is really proximal to the carina. And then finally you do your double kissing at the end. So this should really show you, this actually shows you exactly how it is done. This is the nano crush stepwise technique. So there are really 3 different types where you have the DK crush, you have the mini crush, the nano crush, and it all depends on the kind of angle you are using. Yes, here we are. This is the classic crush, mini crush and the nano crush. And you can see that the different protrusions of the proximal and distal edges of the side branch stent is dictated by the angle between the stent as the side branch and the main vessel. So you can see that in the nano crush it's a very acute angle. Then you get the mini crush, and that is the classic crush. This was once again our main slide. So Stanley, do you have anything more to say about those?
Yeah, I think what you said is completely correct, and you have explained everything. The one more thing that is mentioned is the additional pot. Proximal optimization is going to be very important. And also one got to remember that in this bifurcation stenting that you get a higher chances of thrombosis and also a good guiding support. So you need to maintain your ACT around 300, not less than 300 when you are doing a bifurcation stenting. I would advise you to take ACT in between the case and upload your heparin to make sure that you are in 300. At the end of the case, you might end up with no flow or thrombosis. secondly, that crossing is very easy when your guiding catheter support is very good. So you need to choose a proper guiding catheter and also to accommodate 2 balloons in your guiding catheter. So the approach is depending on the size of the catheter that you are going to make. For a female of thin lady, radial is not going to be very suitable for 2 balloons to send in a 6 French or 7 French guiding catheter. So femoral artery is better, not the radial. So those are few tips and tricks of this technique, and we would welcome all your suggestions, and we'll have 1 or 2 minutes of any questions.
Yeah, regarding antiplatelet, I think even in the DK crush and the coolant, no matter about the selection of antiplatelet according to the Corbis trial and even in strategy trial, they mentioned now with the lesser duration of antiplatelet was introduced with the new generation of the drug-eluting stent, for the recommendation guideline for dual antiplatelet for 1 year. If the patient having bleeding tendency, you can minimize to 3 months of dual antiplatelet. And if you are using a bifurcation stenting for a young people, you can consider more potent antiplatelet like ticagrelor and the prasugrel.
Yeah.
But it's not clearly mentioned about the more than 1 year duration. And in most of the case, even in the Corbis trial, in the DK crush, the final failing of the step, about the final DK crushing was, most of the cases was failed with 9.4%. So we prepared with more guide wires. Even if you cannot cross the side branch, you can use the pilot 50 guide wire, and sometimes you have to use different guide wires as the technique and the micro catheters to recross the side branch. I think we have almost...
Yes.
Yeah.
I think we have come to the end of this particular presentation. I hope we didn't disappoint having the more celebrated speakers. One of whom was who informed me that he's lying somewhere. Sorry. So let us bring this to a close and get on with the next program.
I was trying Nevolia and team actually for taking this up. It was very short one, within 1 or 2 hours. And they were prepared for advance. Actually, we had to cancel because the speaker last moment dropped from the session. So I must thank Nevolia and the team for taking up this one. Thank you very much.